Hello. I'm Elias from Mayo Clinic. I'm a fourth-year resident in surgery, and today I'll be discussing disparities in surgical approach for hepatocellular carcinoma. I have nothing to disclose. So while significant improvements in the survival of patients with hepatocellular carcinoma have been achieved, the 5-year survival rate in the U.S. remains at approximately 5%. The application of minimally invasive surgical techniques for the treatment of hepatocellular carcinoma has been increasing over the past decade. However, studies have identified a multitude of disparities that still exist in the care for patients with hepatocellular carcinoma, which can have significant impacts on the oncologic outcomes within those patients. Because of this, we sought to identify and investigate the demographic factors associated with surgical approach amongst open, laparoscopic, and robotic techniques, as well as the outcomes for patients with T1 and T2 hepatocellular carcinoma in the short term, with another focus on overall survival. We performed a retrospective analysis of the National Cancer Database from 2006 to 2012 using the statistical methods you see listed. Inclusion criteria were patients who had T1 or T2 hepatocellular carcinoma and underwent either open, robotic, or laparoscopic liver surgery. If patients were offered minimally invasive approach, however, had to be converted to an open approach, they were still analyzed within their respective minimally invasive surgical group. Patients were excluded if they had pathologic T3, T4 tumors discovered following the operation, even if they were clinically staged as T1 or T2. They were also excluded if they had adjuvant or neoadjuvant chemotherapy, radiation, or underwent transplant. Our primary outcome was overall survival, and our secondary outcomes included margin status, postoperative length of stay, and unplanned readmission rate. As you can see from this table, there were no significant differences between raw data for open and minimally invasive approach when it came to age, gender, race, insurance status, income, or education. Nor was there a difference in facility type, days to surgery, grade, or AFP status, although there were some differences demonstrated between groups in Charleston-Deyo, clinical and pathologic T-stage, as well as surgical approach. A univariate analysis as well as a propensity-adjusted analysis was performed. With this, we noted that there were increased rates of margin positivity, but decreased length of stay and readmission rate for patients who underwent a minimally invasive approach. When we performed a multivariable analysis of minimally invasive versus open approach, we found an increased rate of minimally invasive surgery predicted by being older, uninsured, having a higher level of education, a lower Charleston-Deyo score, or a lower T-stage. You can see here, however, that there was no difference in overall survival between open and minimally invasive approach. That is despite the higher rate of margin positivity in minimally invasive approach. When we looked at demographic factors predicting overall survival, we found that there was an increased hazard ratio for older patients, but no difference in the other factors. For pathologic and treatment factors, we found that you had a lower survival if you had a higher Charleston-Deyo score, increased pathologic T-stage, positive margins, or longer length of stay. We concluded that minimally invasive approach for early stage T1 and T2 hepatocellular carcinoma has superior short-term benefits in terms of postoperative length of stay and unplanned readmission rates. However, overall survival was equivalent regardless of surgical approach. We identified some unique disparities in the approach for early stage hepatocellular carcinoma, and as minimally invasive approach becomes increasingly applied to hepatocellular carcinoma, and further studies validate long-term equivalency, in addition to the added short-term benefits of a minimally invasive approach, disparities in this surgical approach may become more relevant to the care of our patients. With this being said, we had multiple limitations. We excluded patients who received neoadjuvant or adjuvant chemotherapy or radiation, which meant that we had fewer patients in our analysis, and we were also unable to evaluate disparities related to systemic treatment. We had a multitude of missing information, including presence or absence of underlying liver disease, as well as the severity of an underlying liver disease, and the details of the disease and procedure, such as the perioperative blood loss, whether it was unifocal or multifocal disease, presence of microvascular invasion, size of the liver remnant, recurrence, and other information. Additionally, we utilize the TNM staging because of the database. However, other staging systems have been proposed as being more reliable for hepatocellular carcinoma in terms of prognosis. We have a possibility of reporting bias from discordance in the reporting of race between self-reported data and registry-reported records. We also have the possibility of incorrect categorization of the procedure type because the NCDB defines open surgery as surgery that has been listed as open or unspecified, meaning that if it was unspecified but minimally invasive, it would have been miscategorized as open. In addition, the NCDB does not capture several factors which may have influenced surgical approach, such as individual patient preference or bias, personal surgical experience or surgeon experience, specific treatment center characteristics other than the geographic area and the academic or community designation, and patient past surgical history, such as multiple past abdominal procedures. Thank you.